Hi everybody, and welcome to our module on aneuploidy screening. So aneuploidy refers to an abnormal number of chromosomes, and sometimes the fetus develops either missing a chromosome or with an extra chromosome. In most cases, this is not compatible with life and it will lead to a spontaneous abortion. But there are some forms of trisomy that can lead to a live birth, and we can potentially screen for these during pregnancy. So trisomy 21 is when a fetus has a third or extra copy of chromosome 21, and this causes Down syndrome. Edwards syndrome is trisomy 18, and Patau syndrome is trisomy 13. And so these three forms of aneuploidy are potentially compatible with life, and we offer screening during pregnancy. Now, there is no treatment or cure for aneuploidy, so the reason screening is done is first of all so the parents can prepare if they're going to have a child with one of these syndromes, and also some mothers will consider termination if the baby has aneuploidy. There are a couple of screening methods that can be used. One is through measurement of maternal serum markers. These are substances in the maternal blood that indicate possible aneuploidy in the fetus. There are also certain fetal ultrasound findings that suggest aneuploidy. And finally, there's a test called cell-free DNA, which we'll talk about later. So all of these can be used to suggest possible aneuploidy, but they're just screening tests. And if a mother has a positive screen, that has to be confirmed by obtaining a sample of the chromosomes of the baby to know for sure that the baby has trisomy. Maternal serum markers are substances you can measure in the mother's blood, and if the levels are abnormal, that's associated with aneuploidy in the fetus. So there are 5 important maternal serum markers, and we'll talk about how high or low levels of these markers suggest that the baby may or may not have aneuploidy. Assessment of the nuchal translucency in the fetus by ultrasound is another way that you can identify a finding that suggests possible aneuploidy. So there's always some fluid at the back of the neck in the fetus, and you can see this by ultrasound. And if you measure the size of the fluid collection at 12 to 13.5 weeks, a larger fluid collection suggests that the baby may have aneuploidy. The timing is key. Only in this range here is the measurement valid to predict aneuploidy. And this is a picture of the nuchal translucency on the screen here. You can measure the size of it, and that can be used to determine whether or not there's possible aneuploidy in the fetus. So to screen for aneuploidy in the first trimester, what's usually done is the combined screening test. It's called combined because it combines ultrasound findings for nuchal translucency plus lab findings in terms of markers in the mother. This is usually performed 12 to 13 weeks, like I mentioned on the last slide, late in the first trimester. And basically what you do is you take the size of the nuchal translucency and the measurements in the mother for PAP-A and beta-HCG, and you plug them into a formula. And that formula will give a risk estimate for trisomy in the baby. So the results will be something like the risk of trisomy is 1 in 200 or 1 in 100. The way the risk calculator works is if the baby has trisomy 21, there'll be an increase in the size of the nuchal translucency, the PAP-A level will be low, and the beta-HCG level will be high. In trisomies 18 and 13, there's also an increase in the nuchal translucency and also a low PAP-A level, but in those two forms of trisomy, the beta-HCG levels are low. Aneuploidy screening in the second trimester is usually done by what's known as a quad screening test. This involves only maternal lab findings for serum markers. It does not involve measurement of the nuchal translucency. And this will also determine a risk estimate for trisomy, like 1 in 200 or 1 in 100. So it's called the quad screen because it uses measurement of these 4 serum markers here in the mother. In trisomy 21, the AFP level is low, the HCG level is high, the level of estriol is low, and the level of inhibin is high. What distinguishes trisomy 18 is that the beta-HCG level will be low, the inhibin level is variable in trisomy 18, and then trisomy 13 is very rare, but when you're screening for it in the second trimester, usually the quad screening is not that helpful because the results are variable. There are major ultrasound findings in the second trimester that you can see in trisomy 13, and that's usually how those babies are identified. You can also do a test in the second trimester called the fully integrated test. This involves ultrasound parameters plus lab findings from the first and second trimesters to give a combined risk assessment of trisomy 21 or 18 only. So in the first trimester, you take the PAP-A level and the nuchal translucency by ultrasound, and in the second trimester, you take the AFP, estriol, inhibin A, and beta-HCG levels. You plug all these things into a risk calculator, and it gives you a risk estimate of the risk of trisomy 21 or 18. So for years and years, fetal aneuploidy screening has been done through a combination of fetal ultrasound findings and measurement of serum markers in the mother's blood. But a newer way to screen for aneuploidy that's becoming increasingly popular is known as cell-free DNA. The idea behind cell-free DNA is that there is some fetal DNA that is detectable in the maternal circulation, and if you can identify this DNA, you can use it to screen for aneuploidy. In order for this to work, the mother's plasma has to have an adequate amount of fetal cell-free DNA, so sometimes when you send this test to the lab, it comes back as no result, and that means there wasn't enough quantity of cell-free DNA to perform the test. Cell-free DNA is not used before 10 weeks because the levels are too low, and also there are low levels of cell-free DNA in obese women, and this can limit the ability to use cell-free DNA testing in all pregnancies. It's important to understand that cell-free DNA is not diagnostic. Even though it represents fetal DNA, it's not the same as looking at a sample of fetal tissue and directly measuring the chromosomes, so it's used only for aneuploidy screening. When there's a positive test for aneuploidy, it indicates a high likelihood that the baby has some form of trisomy, but there are rare false positives and also false negatives, so once again it's only used for screening, and you have to follow it up just like other screening tests for fetal aneuploidy. Cell-free DNA isn't universally available in the United States, and it can be expensive, but when it is available and it is affordable, it's the most sensitive and specific testing method available to screen for fetal aneuploidy. Initially, it was only used for follow-up of abnormal serum or ultrasound testing, but more and more it's being used as the primary method of screening for aneuploidy. In other words, it's replacing measurement of serum markers in many practices. And there was a new recommendation from ACOG in September of 2020 that said that when cell-free DNA is available and not cost prohibitive, it should be used as the primary screening test, and that's because of its high sensitivity and specificity. So depending on where you rotate in your training, you may see maternal serum markers measured, or you may see those measurements being replaced by measurement of cell-free DNA. One of the maternal serum markers we talked about was alpha-fetoprotein, which can be used as one element of the quad screen, but the AFP level also has value in and of itself. The level varies during pregnancy, but if the level is high or low, that can suggest certain problems with the baby. When you measure a mother's AFP level, it's reported as a multiple of the median for gestational age. So a woman whose measurement is exactly equal to the median for the gestational age of her pregnancy would have a result of 1. Reduced AFP levels, less than 0.5 multiples of the median, are seen in trisomies 21 and 18. This can also be seen if there's fetal demise or if there's incorrect gestational dating. If, on the other hand, the AFP is increased, which is more than 2.5 multiples of the mean, this is a finding you can see if the baby has a neural tube defect or certain abdominal wall defects like gastroschisis. You can also see high AFP levels in multiple gestation pregnancies, and then the level can also be high if there's incorrect gestational dating, just like incorrect dating can make the level be low. So now let's talk about invasive diagnostic tests for aneuploidy. Everything we've been talking about now is just screening for aneuploidy, but if a mother has a screening test that suggests a high risk of aneuploidy, the only way to know for sure is to obtain fetal DNA. This is required for the definitive diagnosis of fetal aneuploidy. There are two methods by which we do this. One is chorionic villus sampling, which is done early in the first trimester. The other method is amniocentesis, which can be done later in pregnancy. Both of these carry a risk of fetal loss, so we only do them after a mother's had a screening test that suggests a high chance of aneuploidy, where we need a definitive diagnosis. In chorionic villus sampling, a sample of the placenta is obtained for analysis. Some of the placenta derives from the fetus, so there are fetal chromosomes in placental tissue, and you can analyze them to determine if the baby has trisomy or aneuploidy. There are two approaches. One is the transabdominal approach, the other is the transcervical approach. Which approach is taken depends on the operator's preference and the woman's anatomy. In general, the transcervical approach is associated with a higher rate of fetal loss. Chorionic villus sampling is the method you must use early in pregnancy at 10 to 13 weeks because there is not enough amniotic fluid present at this point to do amniocentesis. Chorionic villus sampling carries a risk of fetal loss of about 1 in 100. It can also cause maternal bleeding or infection. And then the other risk of this procedure is it can cause the formation of amniotic bands, and it can also disrupt the formation of the limbs in the fetus. So in some cases, after a woman has had chorionic villus sampling, her fetus develops missing a limb or with a deformed limb. Amniocentesis involves obtaining fetal cells in the amniotic fluid. This is done through transabdominal aspiration, like shown in this picture here. A needle is inserted through the abdomen and a sample of amniotic fluid is withdrawn. This is performed later in pregnancy at 15 to 20 weeks. You have to wait until there's enough amniotic fluid present for this to be a safe procedure. Like chorionic villus sampling, this carries a risk of fetal loss estimated to be at 0.1 to 0.3%. Most women are quoted a risk of fetal loss of 1 in 500. And then you should be aware that amniotic fluid is clear, so the sample should be clear. In some cases, the sample is green or brown, and this is bad. This is associated with adverse outcomes. It means there's been some cause of intraamniotic hemorrhage that predated the amniocentesis, and when you get this finding, it indicates an increased risk of spontaneous abortion or fetal death. And that concludes our module on aneuploidy screening.